Look at spectrum of open bites.
Khi anh chị nhìn qua một cái dải những cái
There is no one definition of open bite.
thì cái
Okay?
định nghĩa đó là gì?
So if you look at the soft tissue,
Khi anh chị nhìn vào cái
what you will see is some patients have open bite and they don't show upper incisors.
mà không có nhìn thấy được cái răng cửa trên.
She has a big open bite. Not only she shows upper incisor, but she shows gingival tissue.
Nhưng mà còn ngoài thấy hết cái răng
And
cửa
this guy, you can see, has a big open bite and there's a curvature.
nhưng mà ở trên cái cung
And this guy has a huge amount of open bite.
anh này là cắn hở quá chừng.
So now you can see that
Bây giờ các anh chị có thể nhìn thấy
you can never define open
cắn hở là
bite.
có thể định nghĩa được là cắn
Now we come into the supplementary fills.
bây giờ khi mà mình
Well, when you read articles in the literature or in the books, people are always talking about steep mandibular plane, long face, this. It's okay. But take a look at it.
dài này nọ ha, nhưng mà nhìn đây nè.
Pretty good facial architecture, there's open bite.
Cấu trúc xương của bệnh nhân tương đối
Steep mandibular plane, there's open bite. Very steep mandibular plane, open
nó
bite.
dốc hơn, cái này dốc hơn.
Crazy open bite.
Còn cái
So,
dưới này là cắn hở mà cắn hở một cách điên cuồng.
skeletally, you can have a flat mandibular plane, you can have steep mandibular plane, you have a long lower vertical facial height,
Nó
short,
dốc, hay là nó không
open
dốc,
bites
hở đây,
can be
nhiều
there.
hay một ít ha. Thì khi
Next.
mà mình thấy những cái
Now we come into dental.
như vậy thường nó sẽ kèm cái cắn hở.
It's a totally crazy situation because dental, you will see anterior open bite, posterior open bite, lateral open bite starting from the molar, starting from the canine, starting.
Cắn hở bắt đầu từ răng
So,
nanh, cắn hở bắt đầu từ răng cối
So we are dealing with
thì bây giờ
a
chúng ta
problem
đối diện với những
which is very unique.
mà nó rất là
There's no way to tell you that you can use this appliance to correct open bite. Every patient has to be individually
ví
treated.
dụ cái không thể nói rằng mình sử dụng cái
And that's why
cắn hở được.
with aligners, it is very difficult to treat objectively
Mình phải điều
a open bite patient.
theo một
The
cái
reason for that is you can only do a few things. You can extrude primarily, eat not too much, very difficult.
trồi ra một chút xíu.
So how are we going to treat some of these problems? And we are going to show you.
Nó lại không phải là những
So, sorry.
đầu tiên
So if you take a look at this thing,
khi mình nhìn cái đầu này
a open bite, I would have a treatment based on the degree of difficulty.
theo cái cấp độ
And the degree of difficulty is going to be based on the soft tissue,
cắn hở gì
dental, and the skeletal
nó
problem.
sẽ phụ thuộc vào là vô
If I have an easy problem, I can just use elastics.
nhưng mà nó dễ
If I have a little bit more complicated problem, I maybe need molar intrusion.
phải luôn
If I have a more complicated problem, I may need some distalization, some easylization, different movements.
phải kèm theo
Or I'm going to need DADs.
hoặc là mình cần phải
But I can do DADs here, I can use DADs here. So the nice thing about DADs is I can use them in any type of situations, easy to difficult.
tùy theo những cái
This is how I look at it.
sẽ quyết định con vít mình cắm ở đâu cho nó thích hợp nhất.
Where does this patient fit in? Is the problem dental, skeletal,
Mình nhìn một bệnh nhân cắn hở
or
mình sẽ
soft
làm
tissue, or combination
cắn
of
hở
all
đó
these
là do
things?
răng hay do xương hay do mô
Let's talk a little bit about biomechanics.
yếu tố đó thì khi mình nói
When we talk about biomechanics,
nói đến sinh cơ học
and when we use these wires, we start putting bends in the wires. Every bend in the wire has a
biết là
consequence.
trên cái dây mình sẽ có bấm những cái
And this is showing you basically the 6 different ways you can put bends in. You can have step bend, you can have bracket or teeth are up and down, and your wire is straight, or you can have teeth leaning towards one side, and you will see the force system is almost the same. So which system I'm going to use if I'm going to correct dental open bite in my patients? Ideally, if you look at open bites, they are primarily because of the upper dentition, not because of the lower. That lower you will see a little bit steepness of the occlusal plane, but in the upper you are going to see the problems in the posterior region or anterior or vice versa. So So when I want to use biomechanics in open bites, there are certain things are common with most of the problems. Is I always want to have an intrusive force on the molar. Why? You extrude the molar, you increase the open bite. I don't want to do that. The other thing is I would like to make this occlusal plane flatter based on your treatment plan. So in some treatment plans, I need a lot more intrusion, less extrusion. In some, I want to keep the molar where it is, and I want to extrude the teeth because I want patient to show upper incisor while smiling. So different clinical situations. So, for example, if you look at 4 different scenarios of biomechanics, you have first what we call class 4 geometry, and that is extrusion arches. And what you will see is that if I place a cantilever on a one piece extrusion arch, and I hook it on the anterior teeth, I'm going to have a force system. The reason I'm showing you this is that any time you place a wire in the mouth, you should know what you are doing. You decide what wire is going to do, not the wire deciding what it is going to do. So, if I do this thing, I'm going to have intrusion in the posterior region, and I'm going to have extrusion in the anterior region. But then what happens is the moments are going to be quite different. And that is, it is going to bring the posterior teeth forward and anterior teeth down, and the net result is you correct one problem, but you create another one in the posterior region. So what do we do these days? What I would like to do is for you to place a dad somewhere there, put in a wire, passive wire going into the tube. That is your indirect anchorage. Now you can do anything in the anterior region you want. There's no side effect in the posterior. This is where orthodontics should be done. Why does it take us to treat 2 years, 18 months? Because half of the time we are correcting side effects. And you want to use DADs so you don't have side effects. You can finish treatments faster. More predictable tooth is going to take place. So I'm not going to spend most time on these things, but take a look at good effect, reduces overbite, bad effect, occlusal plane changes. Very quickly showing you, if I use step bends, everybody thinks, oh, if I put a step bend, upper teeth are going to extrude. Well, that's maybe true, but you're going to have side effects. Force system is okay, moments are not. So net result is, if you don't have a DAD in the posterior region, you're going to have a problem. So how do we get rid of this problem when you do these mechanics in your practice? You use box elastics. So anytime you use up and down elastics, you are saying there's a problem in the lower, there's a problem in the upper, and it's equal amount of problem. Now the problem is primarily in the upper. Maybe I don't want lower teeth to move. So box elastics is not the best way to do it. A lot of you use probably meow wire. But every open bite patient, you give the meow wire. It does the same thing in every patient. You don't want that. You want different appliance, different force system, and all these different problems. So that's no good. And then I can say if I use center V-bend, especially if I have an extraction patient, I put a loop in the middle, and I activate the loop, what is going to happen? Well, then we have opposite moments. So now you can see in this day and age, all the side effects I'm going to take care of by using DADs. If I don't want posterior teeth to move, I use tabs. If I want posterior teeth to intrude, I'm going to use tabs. I can use palatal tabs, intrazygomatic tabs, buccal shelf tabs, different ways. So you can see this is another thing we can do. You know the side effects. And then the last one you can do in treatment plan is, okay, if I put a band in the front, what is going to happen? Well, longer the wire, smaller the moment. Shorter the wire, bigger the moment. So, there you are. Force system in all these is okay. It is the moments which are going to create problems for you. So now you can see posteriors are going to look pretty good. The anteriors are not going to look good at all. So we may need tabs in the anterior region. But we can. It's an open bite case. So you have to be very careful of the force system. So this becomes very important. Now we come into research, what goes on, okay? I'm an evidence-based guy. So this is the paper which we have published. A prospective clinical trial effects produced by extrusion arch, biomechanics. And you can see how many accesses it had. In a short period of time, we had 56,000 downloads in the social media. So you can see this study basically shows that if you use extrusion arches with a better control in the posterior region, you can do a very good job in closing the open bites. Now, what are the common sites for TAD skeletal anchorage application? One is my friend Dr. Sugawara, skeletal anchorage system. In US, it is rather difficult to use because you need a periodontist or oral surgeon to do it. Cost increases. Intrazygomatic tags, buccal shelf tags, and palatal tags. We are going to hear from Dr. Benedict Dumas about palatal tags a lot now. I'm going to talk a little bit about intrazygomatic and buccal shelf tags. This is Dr. Sugawara's system. He always talked about that when you want to do bigger movements, you need these plates in the zygomatic bone with 3 screws, and then you need, if you are using it in the lower, you are again going to need. Now you can apply a force to retract the teeth, intrude the teeth, whatever you want, instead of using a single tab. The best system you can have, but it is difficult if you are not oral surgeon yourself. Very nice. Junji and I wrote a paper in 2006. It was the best paper that year in AJDO, and I remember Junji coming and getting an award there. And in this one, we basically talked about distal movement of the maxillary molars in ongoing patients with skeletal anchorage. So you can see how we are intruding the whole arches. Then, this is another classic paper, 2004. It is the highly cited paper I think I have. You know, I have probably 300 papers. You can see it's very cited because it's one of the first papers which talked about intrusion of the posterior teeth. It was a case report only. And that was skeletal anchorage to correct open bite. It was done with my friend Dr. Kelesh and Dr. Najat Erverdi from Turkey. So what do you see? You see here is I work with people internationally. I met Junji, who was sitting on the second chair in 1980 when I visited Sendai. I was visiting professor there. And then Junji spent 2 years with me. Dr. Najat Erverdi, he spent a lot of time with me over the years. And I'm going to show you some of the cases with Dr. Marcio Almeida, who started coming in 2011 in Connecticut. Now, I think he's probably one of the best orthodontists in Brazil. So you can see, Flavio, look at the screen, please, not your computer. Dr. Uribe, please, he's the chairman in Connecticut now. He thinks he knows everything, you know. You can still learn a little, please. Okay. So you can see, very simple device which we use. This is showing you historically. This is just to give you an idea that suddenly biomechanics plays a big role with the dads. Because when the dads came in, everybody thought, oh, now our problems are over. Well, the new problem started. Where are you going to put dads? What relationship to center of resistance? What is the relation to the line of force to the center of resistance? Oh, really? You have to do that? A lot of research came from Korea. A lot of excellent studies came from Korea because they took it over. So this becomes very important. Same thing in the lower. If you're going to use a buckle serve tag, what is the relationship of the force to the center of resistance? So for example, I'll show you later, then this is from one of our books. You will see if the force is above the line of center of resistance, I can retract the teeth, I can close the open bite. Same thing I can do with the upper by putting the line of force in relationship to center of resistance. These pictures are at least 25 years old, 20 years old. So application of DADs to apply cantilevers. This is a famous paper from Dr. Uribe, but I took it over from him because anything which your students or faculty does, it belongs to the department head, right? You know that, Dr. Uribe? So this is a fantastically treated case just to show you, okay? Take a look at this patient. Scalically, there are no issues. He looks fine. Soft tissue-wise, there's a problem. Dentally, there's a problem. There's an open bite. Now, you don't want to change the posterior occlusion because it's pretty good. So Dr. Uribe started calling this targeted mechanics. You know, the terminology comes from medicine because these days in medicine, there are a lot of medications which are targeted, that you want to take care of the cancer, but you work with the cancer instead of doing the whole medication systemically. So instead of putting brackets on all these teeth and putting a wire and all that, having side effects, the idea here is keep the posterior the way they are, put a TAD here, indirect anchorage, right from the TAD, the force to move the teeth. But in orthodontics, we are like slaves of brackets and wires. Anytime patient comes in, put all the brackets in the mouth. You don't need it. So take a look at it. So we are going to use a force system here of our extrusion arch, because what we want to do is, we would like to put an extrusion arch to bring these teeth down, take care of the side effect in the posterior region, move the lower teeth a little bit up. This is what I call precision orthodontics. It's not like you throw a liner in the mouth, go home, see you in 3 months. Okay, take a look at it. So, now what we have done is, we have indirect anchorage from the TAD, extrusion arch is going into the molar tube, no effect on the molar. We are going to bring the anterior teeth down. So take a look at all that curvature. Occlusal plane is now flattening. So we go here, we go here. This treatment can be finished very fast. Won't take too much time to finish. And then, when you're ready to finish, you can put brackets on the posterior teeth and arch wire and finish up the patient. Okay? Now, if I was in private practice, I would finish it very fast. But when you are in the university, you want to teach your students and you move the molar a little bit like this, and the canine has to be very good and all that. So this is what we call targeted treatment.
Đây là chúng ta gọi là điều trị có mục tiêu rõ ràng.
No change in the vertical dimension.
Thì còn cái nếu mà về
Very little intrusion. You're not going to get much intrusion in any case, the majority of these patients. And you can see the long axis of the teeth look pretty good. You finish up the patient very, very nicely.
thì mình đã chỉnh được cái trục răng nghiêng.
So how much auto-rotation of the mandible takes place with intrusion
Thì bây giờ
of the posterior teeth?
chuyện sẽ xảy ra nếu
Most of the studies are going to tell you it is going to be about 2.5 or 3 degrees. You are not intruding too much, so the auto-rotation is gone, not going to be too much.
thì mình chỉ cần đúng một ít
Okay,
thôi,
so
nhưng nó đúng lại
if somebody tells you they can auto-rotate a lot, just scratch your head, okay?
mọi người biết
It's
đó
not
là
gonna
người
happen.
mà trình bày những cái ca là cái răng
So take a look at it. They looked at 42 articles and they talked about 2.3 to 3.9 degrees.
2-3 độ.
Now we come to open pipe correction, the whole arch discalization.
Chúng ta sẽ điều trị
This is something beautiful happened with DADs in orthodontics. And we are applying the same thing now with aligners.
áp dụng ý
So when I gave my talk the first day, I just said that anytime you have open pipes, space closure, you want to use DADs, use palatal DADs, use intrazygomatic, whatever you want to
các
use.
chị muốn đóng cái khoảng
I'm not selling anything, okay? You can use whatever you want.
cắm ở ngoài, cắm ở trong, cắm ở ICC, cắm ở
But most of the DADs, when I was in Connecticut, we used
các chị giải quyết những cái cách
Forestodent DADs. Because I've worked with Forestodent very closely. Now they come up with the newer system.
nhưng mà ở đây không phải là tôi
More DADs. Take a look at this patient.
anh chị thích xài
It was done in the department. We didn't want to do surgery, nor she wanted surgery. So we said, okay, let's retract the whole lower arch.
bệnh nhân không có muốn trải qua phẫu thuật.
This patient has been done a long time back, and you are using a Sugawara system here.
Hệ thống của Sugawara là cái nẹp ở
We
đây.
set up the lower arch with as large a rectangular wire as you
Ở
can.
đây á, là mình sẽ
In the upper, we leave it alone. We don't want to do too much in the upper.
dây cung chữ nhật cứng chắc.
So sequentially, we are going to change wires, put in there. We are going to apply a force
Dây từ từ cho tới khi cây lên.
above the center of resistance.
Lực kéo của
So
mình nó
not only we will go back, we will close the open bite also.
đi lối nữa.
You want to put as heavy a wire as possible because you want to use all the lower teeth as one unit, as a single tooth.
Lúc này á, khi
You don't want to use over 6 or over 8
nó trở
wire.
thành một cái đơn vị thống nhất và mình nó sẽ chịu cái áp.
And then as you are coming back, you can change the position of the elastic. You can go from here to there to there. Why? Because shorter elastics are going to have more vertical forces.
Tại vì khi á, mà cái thun mà nó ngắn lại á, thì cái
Bye bye, Dr. Bimtar. Have a nice time. Thank you.
nó nhiều hơn.
So,
Cái hàm nhiều hơn.
take a look at it. So clinically, we are doing basically the same thing.
Ở trên
So
đây
this is our occlusal plane, how we would like to bring it back, how we'd like to change. And you can see we start with here. You can see all the way front, and then we are changing.
Đó là cái cách mà chúng tôi đã sử dụng.
So now you can just,
Bây giờ khi mà kéo
we have retracted all the lower teeth
rồi
back.
mình chỉ cần là không
What do you learn? Because whenever you do these cases, you learn something. You know, not everything goes right.
điều này á, là các anh chị
When I look back at these cases, I said, oh my gosh, look at this, you know. The canine is very prominent.
các anh chị sẽ nhìn vào cái răng nanh.
Because when you're bringing this whole arch back, you're going around the corners. You're going to see the canine. They go a little bit more toward the corner. Right? So over the years, what you have to do is you want to make sure that the canine roots are in.
Cẩn thận và cái chân răng nanh nó có thể nó bị lòi ra ngoài.
You're finishing the patient pretty good.
Đi qua cái góc vuốt
We
cong.
could have done better, but again, this is the start. When you're starting something new, I'm showing you beginning. Now everybody is doing it.
Này á, là một trong những cái ca đầu tiên mà ứng
So you can see how it started. You can see the canine roots. You could have done something better. But as far as the patient's smile is concerned, it's good. She looks pretty good overall.
nhưng mà nhìn chung thì cái ca này vẫn
So So what happens with open, in between I put these pictures there to show you what happens with mechanism of open wide closure with TADS. We published this paper in Progress in Orthodontics, and we basically talked about when you use these aligners, for example, without TADS, when you close the open bite, it is primarily because of IPR you do in these cases, and then you bring the incisors back and the lowers back, they come higher. Primary open bite correction is because of relative exclusion. Aligners don't include posterior teeth. In latest study which came from Invisalign patients in American Journal of Orthodontics, 0.7 millimeters of intrusion. And the error of measurements was 0.7. So that means there was no change. And whatsoever. So you have to be very careful. I'm showing you some original patients, older patients. Take a look at this young boy. Interestingly, where is the midline? Upper is here, lower is there. Open bite. We could have treated this patient several ways. We could have used elastics, asymmetric extraction. But you know, when you are at the university, you want to do something different. All open bite patients are going to receive some kind of a tongue crib in the back. I don't like spikes. I like nice rounded things so that they just remind the tongue not to go back. We are going to use the same heavy arch wire. We are going to use a hook on one side, and what we are going to do is basically change the arch. And you can see no treatment is going on in the upper, just a buccal segment and anterior segment. Nothing in the upper. Only elastics are being used on one side with a coil spring, and typically we use about 250 grams of force. So you will see the midline shift is taking place. Midline shift is taking place. It's a pretty slow process. It takes about 18 months to get where we want. And then in the upper, you can see since our open bite is more on one side, less on the other side, we are using a differential cantilever, a two-piece cantilever on each side. One has more extrusive force than the other side until we get a good relationship in the anterior region. So midline is being corrected with TADS, cantilevers are taking care of the asymmetric open bite in the patient. So this is our patient, this is how we finish. This young man. Not the best occlusion, but looks much better than what he had in the beginning. So these are the earlier studies, earlier cases which we did, and we find where we are at this time. Okay? Let's take a look at it. This comes from my friend Marcio Almeida from Brazil. Work very closely with him. I talk with Marcio all the time. He calls me his biomechanics father. Okay, so take a look at it, what he's doing, using a force system in multiple ways. He and I have written many papers together. This is one of the papers in Brazilian. And we are using infrazygomatic TADS and buccal self TADS a lot. The stability of infrazygomatic TADS is not very good, but the more you use, the better it gets. So oftentimes people get up and they say, oh, there's a study from UConn, 30%, 40% loss. The residents are putting in, So anytime you read these studies which come from universities, it's very different. If you talk with Chris Jang, for example, he uses infrazygomatic TADS. He says 6%. So the more you use, the better you're going to be. If you talk with Marcio Almeida, very low problem with stability. Simultaneous correction of open mind. I want to show you a case from my friend Marcio. Take a look at this case. Just like buccal occlusion looks pretty good, anteriorly there is a problem. He likes to use little spikes on the inside, which I personally don't like. So take a look at it. He's using the biomechanics system.
Sử dụng cái hệ thống lực giống như vậy thôi, giống nãy giờ.
He has determined an occlusal plane and he would like to extrude the anterior teeth, maybe extrude the lowers a little bit, and at the same time, he wants to work on the basis of where the center of resistance of the upper arch and lower arch is, and how we are going to apply a force where the whole upper arch is going to come down, maintain the lower arch, finish up the patient.
Rồi thế là mình sẽ kết thúc được bệnh nhân có những cái mục tiêu đó, làm trồi răng trước ha, rồi di sang,
Okay?
đi qua tâm kẽ.
Then you can use up and down elastics if you want, asymmetric, symmetric, finish up the patient
Nếu mà mình muốn ha, không có cấm cản gì hết.
very nicely. Usually he shows also the number of months it took. It typically would be about 14 to 16 months of
Cái ca
treatment
như
in
vậy
these
á, khoảng từ
patients.
điều trị trong 14 tới 16
Take a look at the long axis of the teeth.
Bệnh
Look
nhân
pretty
cái
good.
cạnh dài của cái răng nè nó tốt.
So anytime you are doing a distalization of the whole arch, you got to take the third molar out of the picture.
Cái khung răng á ha.
You don't want the third molars
Sử
to be
dụng,
there.
mình phải chụp lại cái phim để xem là cái
Okay,
khung răng nó còn tốt.
showing you how much change, 12 degrees of occlusal plane change in this patient.
Rồi, trong phim với bệnh nhân.
Let's take a look at another patient, asymmetric open mind, patient went I think it may be a different patient underwent condylectomy. This is from University of Connecticut.
Đây là bệnh nhân
I think Dr. Uribe was probably
có lẽ là bác sĩ
the
Uribe
instructor.
là cái người hướng dẫn.
So you can see asymmetric growth is going on. This patient had a condylectomy,
Ở đây bệnh nhân
12 months of intrusion with intrazygomatic tabs in this patient. Our launch is going on at the same time.
và sử
9 months of finishing in this patient.
sử dụng cái cơ học mà nãy giờ
Just to
mình
show
đã
you
nói
what TADs can do.
và có
If you were talking about open bites all day, you can spend
thôi là đã
15-20 minutes talking about this case. No case goes in straight line. A lot of times you have in-between problems, but you are correcting those problems. And once you have established the protocol, the next patient is going to become much easier for you at the same time.
nhưng mà mình phát hiện ra rắc rối.
So there's a patient at the end of the treatment.
Giải quyết những cái rắc rối trên dọc đường đi. Chứ
Compared to
đừng có
what
lần
she
trước mình
was.
còn cái ca này là
Buccal shelf tads to distalize the whole arches, simultaneous correction of open bite.
thì mình có thể
Take a look at this case.
cái khung răng.
On the left side, I'm showing you level 4 problem in this
Là
case.
đây là nó nằm ở cấp độ khó xuống
If
cố.
you take a look at
Mình nhìn ở đây,
buccal shelf tad there, line of force,
mình nhìn cái đường
and you can see now what is going to happen. If your line of force is above the center of resistance, the whole arch is going to go this way, and open bite will be corrected, everything is going to come back.
nó sẽ xoay và đóng lại cái cắn hở phía trước.
My friend Marcio Almeida does a beautiful job with all
Đó
these.
là một cái
So extraction of the molars
bây giờ mình nhổ răng số
is
8.
going to take place. And take a look at the amount of class 3 on each side.
Nha. Ban đầu á là nó hẹn
Now you can see a heavy wire is put in.
bây giờ đã lên
A lot of times we may start with 1725 and change to 1825 or
dây
to
18,
Go to
25
5.
hoặc là
You can use stainless steel, you can use beta titanium
hoặc là
wires.
beta titanium nha.
The length of the hook is very important because you don't want to go below the center of resistance. You're going to open the bite.
Cái trong ca này là không muốn
Biomechanics.
đi dưới tâm thể, mà nó
Everything
phải đi
is
trên
based
tâm
on
thể nha.
biomechanics
Còn
in
nếu trong
these
trường hợp mình
cases.
muốn nó đi dưới tâm
So
thể,
take a look at it.
cái lực hút
How much distalization has been done in the lower? Now we have class 1. And now you can go in and put in braided wires to finish up the patient.
đã tới
And I'm skipping a lot of wires in between,
làm cái
which have been put in these cases. The idea here is to show you the spectrum
cái ý tưởng ở đây là không
that,
trình bày một cái
how you can use
tất
these
cả mọi
tags.
bước từ nhỏ tới lớn nha, từ cái giai đoạn
I
đây. Mà ở đây
firmly
là
believe in
thấy một cái chất
that you
đời
cannot
rõ
be
ràng,
a
cái
slave
khả năng
of
mà
a
mình sử
system.
dụng tác để mình có rất là nhiều
I learned
cái
that from
tác
Charlie
để mình
Bernstein.
gắn họ.
Because he said when people become slave of a system, they will say, I do
Thì
buy
bác sĩ
progressive,
Bernstein á,
I do
là
buckle shelf,
có
I
một
do
cái
cigar.
câu nói nổi tiếng
You
là
should be able to use
các anh chị
anything
nên
you
học cái
want,
nguyên
what
tắc,
is the best
cái
for a
nguyên tắc
given patient.
chứ đừng có học giống như cái khí cụ, tức là học pháp chứ đừng có học chiêu.
Take a look at it,
Nếu mà
amount
mình
of
học
change
nguyên tắc
which
rồi
we
á,
wanted
thì
in
cái
the
cụ
patient,
nào họ
in
cũng
this
sẽ ứng dụng
patient.
cái nguyên tắc đó để họ điều trị được hết á.
Distillation.
Và ở đây là đi xa.
There we are from clinically, and take a look at it, the long axis of the teeth. You don't see juggling of the roots in these cases because they're using a heavy wire to bring all these teeth back at the same time.
Thì ở đây mình thấy những cái chân răng nó không
There's
có
our
lộn
patient.
xộn, tại vì cái dây mà mình đặt
Finished at the end of the treatment,
tại vì
class
cái
1
răng nó là cái
occlusion,
dây cứng
both
chắc, dây
sides.
lớn, nó giữ sự ổn định của tất cả những cái răng tương đối với nhau nên nó những cái chân răng nó không có lộn xộn.
And cephalometric changes. My friend Benedict Wilmus is going to talk this afternoon. We did a couple of papers with him. But he publishes a lot. He's always in my books. Whatever books I do, he contributes a chapter. He's the guru, along with Bjorn Ludwig from Germany. And they have created a wonderful system. It worked beautiful in maxilla. It works very nicely because you can distalize the teeth. You know, take a look at it. What is the nice thing about it? The nice thing about this is that before they started using tags, we were using wires to distalize the teeth. Now we are using tags, and we can do unilateral, bilateral. We can have a force closer to the center of resistance of the posterior teeth, but all from the palatal side. Now these days they become very important for us. Why? Because if I'm using aligners, especially if I'm using our shape memory aligners, and I have a class 2 patient unilateral, I can have a palatal tags inside and I'm distalizing one buccal segment. At the same time, my aligner is aligning the other teeth. Sometimes I can leave the molars alone, work on the anterior teeth, and when the molars are class 1, I can include them in my whole aligner. So, as we move, we adapt. This is the way I look at it. As we move, we adapt. This is a paper was published in 2020. My name is there because they like me. Otherwise, I don't think I did much in this paper other than I was their department head. But the concept is something which I love. So you can see it's a jumble of wires in the mouth. I mean, we can use Benedict's system, but Benedict's system, you know, in university we don't have money, you know. So we sit down and we say, okay, let's devise ourselves. So you can see we have tags, we know about the force system, and we are trying to include the whole upper arch in these cases. So you can see in the lower arch, there's our patient, or we can intrude the buccal. One of the nice things is that when you're using a system yourself, you can adapt as you go along. In university, sometimes things don't go in the straight line because you're teaching. And sometimes they go, oh, next time patient comes in, oh, gee, it looks worse. Let's fix the problem. So you can see the system works very, very nicely. So, if you are in private practice, Benedict Wilmus has a fantastic system, pre-formed. You just put it in the mouth and you're ready to go. And you can see intrusion. And you can use from the buccal side also infrazygomatic tags so that you don't constrict the arch. In this case, we have the parallel arch going on with a screw. So it just shows you sequentially how these changes took place in this case. 5 months, 6 months, 7 months, and then you take a look at it. how we are changing the force system. You can see these hooks are very strategically placed so that when we are using the force system, we are cognizant of the fact that where the center of resistance of the different teeth or buccal segments is going to be. So there we are, you can see, occlusion looks pretty good, and nobody wants to tackle with this third molar because of the mandibular canal. And there's our patient at the end of the treatment. Open bite is closed. Next patient, she's 29 years old. There she is. Two parallel ties in this patient. You can see the system we are using in the posterior region. Intrusion duration 12 months in this patient. And there she is at the end of the treatment. These pictures are when the brackets are removed. So treatment duration is 2.8 years. That's a long time in this patient. But you can see she's happy, occlusion is very good, smile is very good. One of the things you will notice here is that all these studies in the literature, intrusion, when you do with whatever system, it is never going to be more than 2.5. If somebody says I intruded 4 millimeters, I just said, oh, okay, I can't do it, you can do it. 2.5 is the maximum. Maybe 3 sometimes if you use Dr. Sugawara's system. There's our patient during the retention phase. You can see it stayed pretty good. So this is another case which is published in JCO recently. It is a premolar extraction case, I think. And you can see pretty severe open bite in this case. Shows you how the planning is done, how the post-intrusion system has been created in this patient, how the force system is being changed every time the patient comes in. You are not using the same elastic, same force system. And you can see sequentially that how it has been changed. And one of the things you will see is not everything is going on in a straight line. You can see here the occlusion got into a little bit of a problem. Many reasons. Elastics can break, the screw can come out, but you will see some. But you go back and start again and finish up the patient pretty nicely. With a good smile, good occlusion. Cephalometrics, take a look at it. Almost no intrusion as such. Primarily it is relative closure of the open bite. Even so, a lot of times when we are using this intrusion force, it is keeping the mandible where it is, not actively intruding or auto-rotating. So there's our patient at the end of the treatment, 4 months retention, 24 months retention. Stays pretty good. Smile is good. His hairstyle is good. Management of open bite with Invisalign appliance. As I told you, this is the very latest paper. Oh no, this is 2017. They basically talked about maximum you can correct, and this one is 1.5. This is a paper which came in 22 in Korean dental journal. Talks about treatment of open bite using non-extraction, clear aligner therapy. Again, all these studies basically show is the changes are very small. This is the latest study. They talked about 0.7 millimeters of intrusion. These are all Invisalign cases from Sandra Dye, Ruse, University of Seattle, University of Washington in Seattle. This is our classic case. We always finish our open bite lectures with this case. Because I especially put it there in honor of Junji Sugawara, who's sitting here. Junji, this is the case. Relapse took place. Patient walks in. Doesn't want the surgery. So what are we going to do?
Ở đây chúng ta
We
làm
place an arch wire in the upper anterior and the posterior. We are going to intrude the posterior
ta
teeth.
sẽ làm lún những cái răng sau.
We set up the lower arch.
Thay vì
And then what we are going to do is we use the Sugawara system. We put in plate in the max, in the zygomatic bone as well as in the lower. The lower force, intrusive force is just so that they don't extrude. But primary change is going to be in the upper. So what we want to do is, we want to bring this occlusal plane up to the level of these teeth. And we don't want to do anything with the anterior teeth. So you will see in all these, this is from one of the pictures, Jinji's chapter in one of my books, placement sites. So take a look at it, how we place these. So there's our force system, you can see. Nothing is going on in the anterior region, in the upper or the lower. So take a look at it, the force system. Now we have a cantilever coming in on that side because we are intruding the canine also. Buccal is intruded. And you can see how the open bite is closing because of the intrusion of the posterior teeth. Now you can see. So what do you see? That I am not using the same force in the posterior region in each and every visit. Force is changing. Sometimes I'm moving the posterior teeth, canine, until I can put a straight wire in the patient. So there we are. Now we can put a straight wire in this patient. So if you take a look at 7 visits which took place, how the posterior intrusion closed the open bite in this case. You will see how much intrusion we did. 2.5. 1 millimeter changes about 2.5 degrees of closure. There's our patient at the end of the treatment. This is during the retention phase. This is 3 years retention. And we have followed this patient over the years quite a bit. You can see overall changes are pretty good. Stability of open bite. You can see that you can lose about 1/3 of the intrusion of the posterior teeth regardless of it. So what does that mean? If I intrude 2 millimeters, I'm going to only have left about 1.2 millimeters of it. So, a lot of times you look at these patients and we say, I wish I could have done something different. This is the case done in the department. I think it's been published also. Done with aligners. You can see. So when we are using aligners, you can say, she had surgery done. We are going to use tags just to keep the posterior teeth in good alignment and finish up the patient very nicely. My time is finishing, so you can see a lot of things which we did. So, what is the take-home message? Scalar language facilitates open bite correction. Biomechanics allows simultaneous correction of open bite and moral occlusion. TADs allow intrusion of maxillary arch only. Relapse of posterior intrusion can be 30 to 35%. Aligners without TADs do not effectively intrude posterior teeth. And retention is long-term and may include fixed removable retainers and positioners over a long time. I received a phone call yesterday and a message from Dr. Flavia Artese that somehow this has not been mentioned at the meeting here, and she's inviting all of you to this meeting in Rio. So she sent me this picture. I thought I'll put it here to all of you. I will be there with Dr. Kenji Ojima, and we'll be giving a 2-hour course on shape memory aligners there. These are some of the books. Those of you who missed it, that's the newest book, which is coming out in a couple of months, and hopefully I will see you there. My acknowledgement, first of all,